Okay, so did you see I was able to post those YouTube? Dr. Sinclair Bennett helped me to figure out what you need to do, which is upload videos to YouTube. And then, so they're there for your viewing pleasure, the recording. So, okay. So how's everybody? You all doing okay? All right, any questions related to what we talked about on Monday as far as communicable diseases or the role, different various settings that community nurses work in?
So I have a question.
Yeah.
So I was doing a practice question on ATI, and I kind of can I ask you the question and then tell you what the answer was and then ask my question about the answer?
Well, go ahead and tell me what's your question. We'll see.
So the question was, a public health nurse is using the epidemiologic triangle to plan interventions for seasonal farm workers in the community. Which of the following interventions is targeted at the host? And so the answer was providing farm workers with gloves and hats to use when working. But I had originally thought the answer would have been preventing crowded working conditions, because that is protecting the actual host. I feel like by putting on gloves, that was more so like to prevent the agent from affecting the host.
So, I think I need to see the actual question and all the answers so that I'm able to answer that. So, because I missed part of what the question was.
You want me to reread it, or?
Yeah, or you could
Okay.
send it to me and then we could talk about that and try and figure it out. But it's something, read it anyway. Just go ahead, because maybe it'll help everybody else too. So go ahead.
Okay, so a public health nurse is using the epidemiologic triangle to plan interventions for seasonal farm workers in the community. Which of the following interventions is targeted at the host?
Okay, and what are the options?
Encouraging
Go ahead.
Encouraging farm workers to limit the amount of time spent using vibrating equipment.
Yeah, I wouldn't say that one.
And then it was preventing crowded working conditions.
Mm-hmm.
And then establish regulations regarding the types of chemicals that can be used. And then the correct answer was providing farm workers with gloves and hats to use when working.
Mackenzie, I got that same question wrong as well. And I think the rationale was basically because the migrant workers are working, are coming from different countries, and they bring different diseases with them.
So as the host, because they're carrying the potential diseases.
Correct.
Yeah, yeah. So using the glove, you're right. The crowded conditions will encourage spread, because when people live in congregate living or in crowded conditions, it can go quickly from person to person. But by having gloves and masks, you're preventing it from even spreading from the host to other people. So I think that is the rationale behind that. But yes, congregate or close living quarters will encourage the spread of communicable diseases because people are living so close together. But by using gloves and masks, and they're preventing it from even getting from the host to the other person. You're breaking the chain right there. Does that help explain it a little bit for you?
Kind of. I mean, I just sent it to you. I mean, they did have the rationales there, but I did just email it to you because those weren't the rationales that they said, but I sent it to you.
Okay. And I'll look it over a little more and see, you know, if there's if I can come up with anything else that it could be. But I think that that's pretty much what what it is the masks and the gloves are going to prevent it from spreading to other people. It's stopping it from getting out of the host to those other people, preventing it from that respect. Okay.
So in that context, would you describe changing the working conditions as affecting the environment, like opposite the host and the agent on the epidemiologic triangle?
Well, yeah, because the environment is where the organism actually grows, so, or spreads. So yeah, you could say that. And if you can change the living conditions, that you could stop it there with the environmental impact. Yeah. I think that you could. The problem is with migrant workers, they often, their housing is quite crowded conditions. And so teaching all the other techniques to prevent the spread of the disease is really the key for the nurse there, is to teach those other, you know, hand washing. Social distancing is not possible when you're a migrant worker living in those kind of conditions. So if there's, so I don't know, you know, what's going on right now as far as migrant workers in housing and all. It's actually something that's a good thought, really, to think about that, because there are, you know, there are migrant workers that come in and they work in the fields to pick, you know, work like in California in fruit and vegetable fields, or in Kennett Square where there's mushroom picking. There's migrant workers that work in racetracks. So I don't think, you know, some of those, like horse racing has been cut back, so I don't think it's too much of an issue right now at the tracks. But still, in farms where there are migrant workers, I don't know the answer, but I would hope that the employers of those migrant workers have made arrangements so that they're not living in conditions that are quite as crowded, to stop the spread, particularly during an epidemic or a pandemic. Speaking of, do you guys know the difference between a pandemic and an epidemic? Do you understand the difference? Pandemic is worldwide. Epidemic can be in a smaller, it's still an outbreak, but it's in a smaller area. It's not global. But we have more issues with pandemics these days. Okay, so any other questions there? Okay. Well, let's just review a little bit about, so the class for today is I have home care, hospice, and case management and discharge planning. I have activities that I will open up for you guys, and you'll break out into sessions, and so we will do them in a little bit. But for right now, let's just talk about palliative care, the video on palliative care. What is the difference between palliative care and hospice? Anybody?
Isn't palliative care just kind of like comfort care?
It is comfort care, but so is hospice.
Long term?
Yes and no. Anybody else have any ideas before I go into it a little more?
Would it be that hospice, they're given, it's been determined that they only have 6 months to live?
Mm-hmm. Yeah. So in hospice, the patient has 2 doctors that have to verify that they have a terminal diagnosis with only 6 months, the prognosis is 6 months or less, although as I told you in the lecture, they can live well beyond 6 months in hospice if they continue to meet the criteria. Palliative care is offered to patients that most likely have the 6 month, have it, they have diagnoses that are usually terminal, but they're not ready to sign into hospice. So it's offering a lot of the same services that you can get while you're in hospice, but the difference in palliative care is that patients can still go for treatment. So they could still be getting chemotherapy or radiation. They can still be a DNR if they want to be. Actually, being a DNR does not preclude somebody from being in hospice, but generally speaking, even if a person does sign into hospice and they still want to be resuscitated, usually they very quickly change that to a DNR status once the hospice team works with them and they start to really come to the realization that their life is coming to the end. So in palliative care, it's often looked at as sort of a stepping stone for patients to still receive supportive services, but they don't have to meet all the strict criteria of the hospice eligibility. If they're receiving palliative care at home, it's typically under the home care benefit as opposed to the hospice benefit. It is under the home care benefit, which means you think about home care and what I talked about home care, what are some of the criteria to meet that have to be met for somebody to be eligible for home care? They have to be homebound. They have to have a skilled need. And it has to be short-term intermittent care for home care. And the visits go from more frequent at the beginning and they decrease over the 60-day plan of care, which is what the orders are for. You have the orders sent to the doctor for 60 days. So somebody who's receiving palliative care would be under home care. So a lot of agencies have both home care and hospice. They provide both services. And so they have these patients that start out in palliative care, so they would be under their home care department and have to meet all those criteria I just talked about. Whereas in hospice, the visits increase in intensity as a person gets closer to the end. They're not restricted by homebound status. So that's one difference between home care and hospice is the homebound status is not an issue when you're in hospice. You can go out and about. Your family may be the one driving you because if you're in hospice, you're probably pretty sick. But so someone in palliative care can only receive palliative care services as long as they meet the home care criteria. So one of the ideas behind palliative care is that the team that works with that patient at home helps them to come to accepting their terminal illness, and then they sign into hospice. Oftentimes in the hospital, and as I spoke in the video, we spend more healthcare dollars in the last couple months of a person's life. If you think about a lot of some of the elderly that go into the hospital that are very sick, at the end, they put them in ICU, they do all kinds of treatments and all kinds of interventions and tests and do all these things to keep somebody alive rather than so rather than all this technology and IVs and all the disruptions that come along with being a patient in ICU, it's the doctor, and it has to come from the physician, the order for palliative care. It could be the nurse practitioner, but I mean, a nurse who's working can't say, oh, you would do better in palliative care. They have to talk to the doctor about it. And then, the team decides and they get palliative care. But it's again, that comfort care, and it reduces some of those healthcare costs at the end, and trying to keep people alive that really have reached the end. And that's a difficult conversation sometimes to have with somebody. If you think about it, we don't like to think of our own mortality or our loved ones' mortality. And so sometimes families want everything to be done to keep somebody alive, no matter what, at what cost. And so all this money is spent at the end of someone's life to keep them alive, when they could have had much more, their quality of life would have been enhanced had they had comfort measures, and not all these invasive procedures that can happen. So the idea of palliative care is, the mindset of palliative care is changing in our society. And because I think people are beginning, there's more awareness and understanding of the fact that isn't it better to have quality at the end instead of quantity? But it's a conversation you have to have with your team members as you're working with patients, if you're in the hospital in those settings. So palliative care is, as he said, what do you hold sacred, and trying to meet somebody where they are in terms of what they do hold sacred, and helping them, whether it's going fishing or riding a motorcycle or whatever that is, but trying to be able to provide that for somebody is the idea, one of the ideas behind palliative care. So increase quality and decrease healthcare expenditures, and really helping people to come to acceptance, really, which is what it's about in terms of hospice, and palliative care that will move somebody into hospice for those final months of their life. Okay, let's see, we also had a video on with the home care. You watched the video of how the visit was conducted, the steps of the home care visit. So the nurses, generally speaking, have a caseload that they manage of sometimes 20, sometimes more, depending on the acuity of their patients. And then each week, a nurse fills out their schedule for the week, but that changes constantly, depending on what's happening with the patients that they're seeing. And so they make arrangements to see their schedule, what patients are Monday, what Tuesday, so on. So they call the patients, they make arrangements, they go out and they do their visit. Now, the visit that you saw in the video was a nurse doing an initial visit. So in home care, the initial visit takes a lot more time than follow-up visits. I talked to you about the admission assessment forms, and then the ongoing assessments forms used in home care. It's called OASIS, right? Outcome Assessment and Information Set. So the nurse goes out, she makes arrangements, or they make arrangements with the family and the patient, what time they'll be out there. They give a window of time. And then they go out and they have their nurse's bag. So in home care, there's a home care bag that a nurse carries. And the nurse carries in that bag paper towels, hand sanitizer, extra dressings, extra catheters, their blood pressure cuff, their stethoscope, and any thermometer and any other equipment that they may need for that visit that day. So when the nurse goes out there, we have in home care the bag technique. Does anybody remember what the bag technique? I talked about that. Do you ever put your bag on the floor? Nope, never. So paper towels are in your home care bag. You take them out, you put the paper towels down, you set the bag on the towels. And that way you're trying to prevent cross-contamination. So you have a barrier for the home care bag because you're taking that bag from house to house to house. Now, in the age of COVID, I'm sure that home care agencies have put in a lot more precautions and measures to help reduce the possibility of transmission. Although they're finding that COVID is not so much living on surfaces. But still, I'm sure that there are some new protocols in place for home care nurses as they go from home to home. So the nurse does a full head to toe assessment on the initial visit. The nurse has to do medication reconciliation. That is a huge component of what they do on that first visit. They look at the discharge paper from the patient. They look at the medications. They ask the patient to bring their medication so they can see what they're taking and if it matches what's on the discharge, or so either they're taking something that's not on that discharge list, or there's something on the list that they're not taking. So whichever way, they have to reconcile it. So anyway, the nurse does their complete visit, their head to toe assessment. The OASIS is extremely comprehensive. It's all done electronically. The information is then sent at the end of the visit. It's uploaded to the agency. It's reviewed by their quality nurses and ultimately electronically sent to CMS, Centers for Medicare and Medicaid, and they're the ones that do the reimbursing. But those criteria have to be met. And we'll talk about that in a minute, but as far as the medication, after the nurse completes their medication reconciliation and their assessment, and that includes watching the patient ambulate because they have to document how the patient is able to ambulate. Good way to do that is have them ambulate into the bathroom. Then the nurse is in the bathroom and can look in that bathroom and see if they have equipment in there that is safe, that will keep them safe. You know, do they have handrails to get in and out of the shower? If it's a tub, can they climb over, or do they need a shower chair? So that's all of these assessments are completed on that first home visit. So you can see it takes a long time. The nurse plans the intervention. So if you think about nursing process, right? We know what the patient's diagnosis is. We go into the home, and now we like I told the fundamental students, and I probably told you guys, you know, your nursing diagnosis, you're not actually writing a nursing diagnosis, but you know in your head what's going on. But you have to develop how often you need to see that patient, what other services are going to be included in that visit, you know, PT, OT, speech, home health aide, social worker. Those are all of your team members, okay? PT, OT, speech, home health aide, social worker, and RN are the 6 disciplines that can be involved in a home care visit, if it's appropriate. Not every patient is going to have all those services. It's only if it matches what their diagnosis is, okay? So, somebody's in there. I have to admit somebody, okay. So After the nurse completes the assessment, does all the medication reconciliation, determines in their mind what services would be appropriate for the patient. The nurse doesn't make that decision on their own. They have to consult with the patient and the family to decide which of these services they would want. So, and sometimes the order already automatically has an order for PT or OT or speech. Do you know the difference between PT and OT, what they provide?
Isn't physical therapy mostly from the body and OT is like speech and stuff? I don't know.
No, OT is more fine motor skills and upper body. PT is more gross muscles, larger muscles, and works more with ambulation, stairs, that sort of thing. So there is some crossover between a PT and an OT, but if you have a patient who is having trouble with, you've heard ADLs, you know what that is, right? Activities of daily living. Well, in addition to ADLs, we look at their IADLs, and I stands for instrumental activities of daily living. How are they able to cook? Are they able to use their phone? So it's sort of the day-to-day things that we do. So that's included in the OASIS assessment. How are they on their IADLs? If they really are having trouble even using the phone, anything that has to do with fine motor, you would recommend an OT evaluation. If someone has trouble with speaking or swallowing, that would be a speech therapy evaluation. We include social service in home health because a lot of these patients may have financial issues paying for their medicine. They may have trouble preparing their own meals. And if they live alone, we would want a social worker to come out there, maybe set up for Meals on Wheels. Social workers can coordinate and get the patient set up with other agencies to help support them to be in the home. Social work can also do some counseling if there seems to be a need for just some counseling as well. And then the home health aide is a unlicensed who helps provide personal care, helps the patient. They have to, under the criteria, the home health aide actually has to do a bath. So they can't just go and do laundry, which is another instrumental ADL. The aide can do laundry if they're in the home doing their personal care, but they can't just do that. They have to do personal care as part of their what they're allowed to do. So the RN decides, again, with the patient and the family, if they're there, involved in this case, these are the services we're going to order. The nurse completes their full assessment, including vital signs, all of the OASIS info, sets up what they think the patient could use in terms of visits, and reconcile the medicines, and now the nurse calls the doctor. The nurse calls the doctor to confirm all of the orders that they're going to write. The RN actually is the one who writes the orders that go on the plan of care, which is called a 485. That's the plan of care. That's the form that goes to HCFA, or Healthcare Finance Administration, which is under CMS. They are the ones that pay the bill. You know, the home health agency gets so much, I don't even, back when I was still doing it, you know, they would get paid like $160 for a nursing visit. I mean, it's pretty expensive, but that's insurance and we don't have to worry about that. So I won't go there. But anyway, so the doctor has to be in agreement with this plan of care, okay? The doctor has to be in agreement, because after the nurse does everything, calls the doctor says, yep, sounds good, let's do that. Then the nurse writes up all those orders that go onto that 485, which is the form, along with the OASIS that goes to CMS for reimbursement. But the 485 actually gets mailed then to the physician. They may do electronic now, I'm not sure. It used to be they were mailed because not all documentation systems speak to each other. So, but anyway, the doctor gets that plan of care, that 485 with all the orders that are listed. And again, it's for 60 days. And the doctor has to sign those orders and it has to be returned to the home health agency within 2 weeks. So basically, essentially the nurse is working under verbal orders because they're not signed yet. They had the signed order from the patient from the hospital to, or if the doctor called the agency and has a patient came in to see them and their blood pressure is out of control and they want home care to go out there to monitor blood pressure and adjust medication till the blood pressure was stable. That would be the skilled need. Anyway, so that's your initial order to go out and start the care. And then after that, you call the doctor, confirm your orders. Then that's considered sort of like a verbal order until that plan of care comes back signed. Okay. But in order for any of this to happen, that patient has to meet the criteria to be eligible for home care services, which again, I talked about with you guys, right? Homebound. What does homebound mean? So you have to know what that means. If somebody's homebound, does that mean that they can get out and go drive? No. Homebound means you don't get out in the car and go driving. Homebound means it's a taxing effort to leave the home and it requires the assistance of either a device like a walker or a cane, something like that, and the assistance of a person to help somebody get in and out of the house. So you can't just freely go and come and go. And I mentioned in the lecture that homebound patients in home care, for whatever reason, they can go to the hairdresser. They think that's Medicare, CMS thinks that that's pretty important, and it is. We all feel better after we get our hair done or cut. And they can go to the doctor's office. Those are the exceptions. So that's in home care. So you need to understand about how it works in terms of the requirements for home care. It's important to understand that the plan of care is for 60 days. If this patient continues to have a skilled need, and that is really crucial to be able to define what is a skilled need, okay? Going out and checking somebody's blood pressure for any length of time is not considered skilled. Because unless the only way that checking somebody's blood pressure is considered skilled is that medication is being adjusted according to that person's blood pressure. Okay. So a doctor's office, so a home care referral can come into an agency from multiple places, including from the hospital, discharge planner, from a rehab facility, from a doctor's offices. Sometimes patients can call it in themselves, but the problem there is what? There's no doctor's order. So if a patient called an agency and said, I really need a home care nurse, you'd find out what that meant, then call the doctor and say, your patient is requesting. So it has to be skilled. Okay, so it can't just be monitoring. So generally speaking, we see somebody like 3 times a week. I listed some of the skilled services that we can provide, like wound services. IV therapy can be done in the home. Teaching someone about the signs and symptoms of their disease and what to do in the event of an exacerbation. So for instance, CHF is a very chronic disease. Well, they have to have an acute episode of the CHF in order to qualify for home care. Because chronic CHF nothing changes really. But if they're in the hospital with an exacerbation of their CHF, they would qualify for a home nurse to go out for a couple weeks to, again, review the signs and symptoms, to report to the doctor any medication changes, daily weights, those sorts of things to help them, be able to live within their means of their disease. So what kind of care, what kind of prevention are we talking about with home care patients primarily? What do you think?
Tertiary?
Tertiary.
Tertiary, exactly. Why? Because they had the disease already, right? Okay, so it's already happened. So home care, and again, because this is a community role for a community-based nurse, and such a great percent of what we do in the community is in the home, that's where the idea, when I talked about in the first lecture about the different levels of prevention, why home care is tertiary. But somebody can be at the maximum on that wellness illness continuum. They can be at the highest level of wellness, even if they have that chronic disease, if we've taught them how to manage it, to prevent them from going into exacerbations. Those daily weights, the things like knowing that they have to restrict their fluids. If they have a 2-pound weight gain, that they need to go back and evaluate how much fluid they had or how much sodium, so we can manage their disease in home. So again, we start with maybe we visit a patient with a skilled need maybe 3 times a week in the beginning, and then we decrease it to 2 times a week and then once a week. In the old days, when I first started in home care back in the 80s, a long time ago, things were a little different. It wasn't as restrictive as it is now, because there was unfortunately a lot of fraud and abuse back in the day with agencies. Just they would send a nurse out every day, and it really wasn't necessary. So now home health agencies, and CMS is looking at it much closer. They have quality nurses that review cases to make sure that you really are providing that skilled service. But anyhow, we, so these patients would be seen, eventually they would be discharged once all their goals are met, because you do have to have short-term and long-term goals in your orders. That's part of your 485 plan. There are some patients, however, that have skilled need that continues on beyond 60 days. The type of patient who may have a skilled need beyond 60 days is someone that maybe they have a wound that hasn't healed. They could be on a wound vac, and as long as they're still meeting the other criteria, they're homebound, okay? And it's intermittent skilled visits, they would still qualify for what we would then do is called a recertification. So we would start all over again with the OASIS recertification assessment form and write another 60 days worth of orders. We used to have patients that had Foley's for incontinence. Well, mostly the ones that we used to have, and again, this is again back in the 80s, things were very different because we don't, not as many people have long-term catheters nowadays, but if there is someone who has a total neurogenic bladder and unable to void, they have to have a catheter, or they have a suprapubic catheter that is put in, and then the home care nurse goes out once a month and changes the catheter. So that's the skilled need, is changing that catheter. And nurses can change suprapubics, not the first go round, but after that, we used to be able to go out. And those patients oftentimes were bedbound, and so they would also get the home health aid. So you can have non-skilled service. A home health aid is not considered skilled in a patient's home as long as there's skilled service. Does that, so in other words, as long as you have an RN or a PT, they're considered your two skilled services and speech, but they can have a home health aide. As soon as all the skilled services are discontinued, the non-skilled service has to be as well, which would be the home health aide and social worker. But for the home health aide, the nurse is responsible to supervise the aide every 2 weeks. The RN writes out the plan of care for the home health aide to follow, and they have to do supervisory visits with them, either in person once a month, or they do supervisory visits and review the plan with the patient and the aide, and they can do that over the phone with the aide. So some patients do keep, that we had patients back then that were on service for sometimes over a year, like for years. If they were alive all that time and they had this Foley that needed to be changed once a month, we would be able to see them. And during that time, they could have the home health aide. If you have patients, and this kind of goes back to some of that, the conversation I had in the beginning about case managers. So in home care, the RN is considered the case manager, okay? That's a role for a case manager, is actually because the nurse in the home is responsible for all the other services that are there, including, you know, the home health aide. They have to supervise that aide. So sometimes you have, so the case manager or the discharge planner in the hospital has a patient who really needs some personal care services, but they don't really meet criteria for home care services. So that case manager would then make arrangements for someone to have personal care services, but they would pay that for that privately. Insurance does not reimburse for private duty services. And you can only get unlicensed help in the home if somebody qualifies for home care with the skilled need, but otherwise it is through private pay. Or someone has long-term care insurance. Long-term care insurance may pay for some of that, but otherwise it's out of pocket, and that's very expensive. So that's why when you think about it, go back to the beginning when a patient is in the hospital, that even the nurses working on the floors, you start that discharge planning on day of admission, right? And you find out what is their home situation, what are they going to be needing when they go home? Will they need services when they go home? And will they qualify for skilled service, or do you need to make arrangements for other services? And again, you know, insurance doesn't pay for unlicensed personal care in the home. So there's a lot of coordinating. You got to see what you can come up with to help people to maintain, because, you know, most people want to be home. That's where people want to be. They don't want to be in nursing homes or assisted living facilities. But it takes a lot for somebody, if they need extra help, you know, you got to make sure that they have that. Okay.
Professor,
Yes.
I had a quick question. Taking it back to the homebound portion, just wanted to clarify. So
Yes.
there's three exceptions, like the hairdresser, place of worship, and doctor's office. Those are the only three places that that patient is allowed to go when they leave their home. So they're not going anywhere else. I'm kind of confused on that. Like, can they go to the grocery store or the park, as long as they can't do that, even if they have someone accompanying them?
No, technically they're not supposed to.
So those are the only three places they can go.
Pretty much, yep. And even the church part, yeah, I think, again, yeah, that's pretty much it. The only other exception I can think of is if there's a family wedding or something like a really, really important event, there can be that exception. But again, it has to be well documented that this patient is going by wheelchair with assistance, that they can't drive. But no, they can't, technically, they're not even supposed to be able to go to the park or something while they're receiving services.
Okay, thank you.
Yeah, you're welcome. Now it's different in hospice. Hospice is the opposite. They can go out and there is no restriction for hospice patients. Oftentimes they're almost too sick to go anywhere, but if there is some kind of a special family event or something, then they will, family will get wheelchair or something like that for them.
And are you documenting for hospice too whenever they leave, or is it not necessary?
It's not really necessary, but you can. So in hospice, again, we had the same disciplines that I talked about in home care. But if you think about hospice with PT, OT, or speech, those are more rehabilitative services, aren't they? And so when somebody's in hospice, our goal is not really to rehabilitate them, but in fact to provide as much comfort measures. So the only time that you may see, and mainly it would be PT, in hospice care, is to teach the family how to transfer the patient, how to turn them in bed, and those sort of things. So, but hospice has, in addition to what I talked about, there is always a chaplain on the team. There's a bereavement coordinator that's involved with hospice. And the plan of care is the same as it is in, you have to write the plan of care with the interventions, the orders, the goals, which in hospice, the goal basically is a peaceful death, comfort free. The difference in hospice is 2 physicians have to sign that the patient has a terminal diagnosis, and the prognosis is 6 months or less to live. So whatever provides comfort and quality to a hospice patient is allowable. The only place the hospice patient can't go is back to the hospital. Okay, because if they go back to the hospital, as I explained, they have, the reimbursement is different in hospice because it is still being reimbursed, let's just say for your Medicare patients, but it's a bucket of money. Remember, the $100 a day is what Medicare, when somebody converts from typical straight Medicare to hospice Medicare benefit, the Medicare benefit is the $100 a day to cover everything that patient needs in the home. But what it doesn't cover is if that patient goes to the hospital. If somebody goes to the hospital, let's say they started coughing and really felt sick, what they should do and what they're taught to do is call the hospice nurse. And the nurse goes out, makes a visit, find out what's going on. But sometimes patients don't want to do that, or they don't understand, and they go back to the hospital. And as soon as a hospice patient goes back to the hospital has to bill traditional straight Medicare. So now their hospice benefit has just been disqualified. So typically they do not go back into hospice, but there are certainly exceptions. You have to figure out what happened. Why did they do that? Did they not understand? There's a lot of reasons. So it's really the responsibility of the hospice nurse to explain that whole hospice benefit before somebody signs the papers that they want to be in hospice. They really have to fully understand what that means. And the only exception, and I believe I mentioned this, would be if somebody fell and say they broke their hip or something like that. The hospice team may send them back to the hospital, chances are they won't do surgery, but they may do something to at least align it. And if it's dislocated and, you know, again, comfort measures, and then they would go back home. So $100 a day sounds like a lot of money, doesn't it? But it's really not, because the intensity of the services increases, as I said, as they get sicker. And with all those different members of the team, plus any equipment, which includes hospital beds, oxygen, because oxygen is used as a comfort measure for hospice patients. So the majority, I'm not going to say 100%, but the majority of hospice patients will have home oxygen delivered. They're in tanks. They plug in, and that's how it works. It's not like those big old green cylinder tanks, although they have them for backup in case there's a power outage. So it's equipment. It could be a bedside table, wheelchair, or a walker. So any durable medical equipment is included under that benefit. All the in-home services, as well as the medication. So the medication, and most patients that are on a lot of medicines, pretty much they'll discontinue the majority of patients' medicines and just focus on the ones that they will take because they need it for comfort. Okay, so in the kit that is sent to a patient's home, that PCS kit, patient-controlled substance kit, includes morphine. It includes, depending, either scopolamine or Levsin, which has helped to decrease secretions. There's compazine, acetaminophen, Haldol or Ativan. So there's, you know, again, different hospices may have different medicines in their kit, but those are sent out to every patient's home, and they have that kept in a lockbox, and they keep it in the refrigerator to be used. The hospice nurse teaches the family how to administer the meds, when to give them, etc. So after a patient in hospice does pass, the bereavement coordinator follows that family for up to 13 months. So a year plus a month. A lot of patients don't want bereavement past maybe a month or 2 or 3, but it is available, and that all has to be paid. So that comes out of that $100 a day benefit. Let's see. So they have interdisciplinary team meetings in hospice every week. So they coordinate. So they usually do the first part of the alphabet week 1. So A through M, and then N through Z is week 2. Then week 3 is back to A, you know, so they alternate it. So every 2, even though the team meetings are weekly, you actually discuss your patients every 2 weeks. The downside, well, it's not a downside, but the part that is difficult about hospice is oftentimes patients don't want hospice until the very, very end. And by then sometimes patients are in hospice for 24 hours or less. I can tell you many, many times I've heard, you know, from people that they don't want hospice because I think it means they're giving up or it's the end. And then once they realize that it really is getting very close to the end, there's nothing more can be done, then they want hospice. And they may have the team for, you know, like I said, it could be less than 24 hours, it could be a couple of days, could be, it depends. But they always say at the end, I wish I had signed up sooner, if I had known. Because what happens is sometimes people live longer because the quality of their life is so much better with that team of professionals coming in and helping them, guiding them through this whole end of life process. And the goal of hospice is always a good death. And that sounds contradictory. What do you mean a good death? A good death is when somebody dies surrounded by their loved ones, they're out of pain. And it could be that they have music that they love that's playing. Whatever a good death means to that person, that's what the hospice team works towards achieving for them. So it is inevitable that families will say after it's over, oh, if only we had started hospice sooner. So that's an education piece for us as nurses, is really to educate our patients. And palliative care is a stepping stone to get someone who may not be 100% ready for, say, oh, I'm don't want hospice. That means I'm going to die. That is actually the words that I have heard people say. It means I'm giving up. But palliative care helps them to understand that you have a terminal illness. Now let's do what we can to make you comfortable and provide you with the best quality of life in your remaining days. So,
Excuse me, Professor.
yes, please.
Did you say with hospice that usually they discontinue the patient's prescription medications, like their heart medications or things like that?
Sometimes they do, or if the patient still takes them, it's not covered under hospice benefit. Okay. But a lot of times they might stop, people that are on, and unfortunately there are people that take a whole lot of medicine, half of which they probably don't need to be on anyway. But they'll stop some of those medicines. Now, something like a thyroid medicine, no, they wouldn't, because you need the thyroid medicine. The heart medicine, depending on what it's for, but they could, they do sometimes, or they at least won't cover it under the hospice benefit. So what else do you guys, any other, like I said, when somebody reaches 6 months in hospice, they don't get discharged. Somebody can be discharged from hospice if they get better enough that they're not meeting the criteria. So someone with cancer, that's usually, that kind of a diagnosis has a more terminal kind of endpoint to it. But somebody with Alzheimer's, I think I may have even told you this during the voice thread. My mom had dementia and she was really going down. She had stopped eating, and so she was signed into hospice. Well, she rallied and she started eating and she was doing great. And they said she doesn't meet the criteria. I said, I agree. So she was discontinued from hospice. And then a couple months after that, then she really did start to go down, and we admitted her on Thanksgiving. And this was back in 2012. So 2011 on Thanksgiving Day, we signed her back into hospice, and then she died in January of 2012. So she lived for about 60 days in hospice care, or a little less. Whereas I think I also told you that the example of my dad and my father-in-law, both CHF patients, both ended up in hospice because they did not want to keep going back to the hospital, which is what happens with these CHF patients. Anyone with chronic disease, it becomes a revolving door for them back and forth to the hospital. And I said earlier this morning, yes, in home care, we teach them, if they've had an exacerbation, they've been in the hospital, they come home, we can go again through everything, how to manage that CHF, but that's all we can do. And then they end up back in the hospital. So there are patients with these chronic diseases that are really, and both Dad and my father-in-law were in their 80s at the time, and they were tired. They didn't want to do it anymore. And so both of them qualified for hospice, because without treatment, you will die within 6 months from congestive heart failure. It just, that's the nature of the disease. So both of them met the criteria for hospice, went into hospice care, and both of them, again, my dad was in Florida, my father-in-law was in Southern Maryland, but they both lived 10 months on hospice services. They never ever had to go back to the hospital, because every time they would have an exacerbation, the hospice nurses had instructed them how to use the medication that was in the PCS kit. And they were able to stay home, and they had quality of life till the end. So 6 months is the standard term that they use, the prognosis expectation of 6 months or less to live, but certainly you can live beyond that and still qualify for hospice services. Let's see. We talked about and as I said, the goals of hospice, we talked about that, which is a peaceful, a good, they call it a good death. There is a booklet that I have, it's called, can you see this? It's called Gone From My Sight. And this is a booklet, it's probably backwards, I don't know if you saw it, but anyway, this booklet, when a patient's admitted to hospice services, there's a packet of information that they are given. And including in there is this booklet, and it's The Dying Experience. And it is a way, the nurse will go over this booklet with the family, and they'll leave it in the home, in the packet, about things to expect as the patient gets closer to death. What happens 1 to 3 months prior, as far as withdrawing from even communicating with your family, stopping food, then 1 to 2 weeks prior, and so on. And it talks about how breathing changes and physical changes. And so oftentimes towards the end, your blood pressure goes down, starts to lower. So that's another reason why some of those other medications could cause your blood pressure to be even lower, Carol. So that's another reason why they would stop the medicine, because it's actually, as someone's dying, they have these physiological changes that therefore eliminates the need to continue with some of those medications. And so this is just a nice booklet that patients are given. When a patient is admitted to home care, they also are given a packet, an admission packet, and it has everything in there, including what to do in the case of an emergency and how to respond. So in home care, remember, we can only admit patients if we feel that they are safe in the home, okay? We can't admit somebody if they're not safe. If they live alone and they don't know how to get out, or they can't use stairs, there's a great chance they could be falling. So it's on that first admission visit, the nurse also goes through this entire admission packet, and they include everything about safety in the home and knowing who to call in the case of an emergency. Whether they call 911, they explain the difference when you call 911 versus you call the home care nurse. Home care nurses, as well as hospice, are on call 24/7. There's always somebody available, both in home care and in hospice services. And they make visits during the night if necessary. More so in hospice, if a patient, when they die, say they die at night, the hospice nurse can actually go out and pronounce the patient. And then they call the doctor and the funeral home, because all those arrangements are made ahead of time. But in home care, they will make home visits during the night as well. But before that nurse even admits that patient to home care, they have to make sure that they are safe until the home care comes back. Because home care, including the aides, visits are, the only time a visit is going to take maybe up to 2 hours is if on that admission visit, because there's so much information to be gathered in terms of your assessment, and then, you know, working through the plan, setting the goals with the family of the patient, and then calling the doctor, preferably calling the doctor from the patient's home if you can get a hold of the doc, to then make sure they understand their medicine. But safety is really a key component of someone. Now, safety does not mean if they live in a bad neighborhood, in a neighborhood where there's high crime or drug dealing taking place on the street corner. That's not the safety reason that would preclude you from doing, for providing home care services. I'm talking about in the home. In the home, if a patient environmentally has a very dirty house, and there are people that don't, they could be a hoarder, or they could just be somebody who doesn't bother washing dishes, and dishes pile up high in the sink, or there could be a house that is infested with roaches, which you will often find happens, especially in home care in the cities, in row houses. But not just row houses. People in beautiful single homes may have, you know, infestation of rodents, or could even be mice. Out in the country, people have mice, people have snakes. I had a big snake in my house about 1.5 years ago. That was scary because I don't like snakes, but anyway, I was able to get him out with a broom. It was a big old black snake, so I knew he wasn't poisonous because we don't, you know, but still. So depending on where the person lives, there may be environmental things going on in that home, but that, unless it's going to directly affect the patient's overall safety and health, that's not a reason to not admit a patient to home care. So they have to have, so in that admission packet, the nurse does go over the whole criteria for safety in the home, and who to call in the event of emergency. It is very important that if a patient needs equipment, that equipment is in the home from the very first visit, okay? So that falls back on the case manager or the discharge planner. So I went through that in the lecture. Do you guys understand the difference? There is some crossover, but the difference between a case manager and a discharge planner? Case managers has a much broader role. Discharge planner is specifically working to set up a discharge for a patient, which includes ordering any equipment that they need, and that it's in the home prior to the patient getting there. Because if it's not there and they need something, are they going to fall because they can't get, you know, where they need to be because they don't have the equipment? So we really have to anticipate the needs of the patient when we're planning their discharge. And we have to talk to them about what it is in their home, what kind of barriers there may be for them to be home safely. Are there steps? You know, where is the bathroom located? How will they get there? How will they get to the bathroom? Are they able to walk? Do they need assistance? Do they need a commode? What about their kitchen? How's their kitchen set up? What kind of food do they have in the house? The home care nurse on that initial visit may ask. So again, remember when we first interview people, what's the first thing we do? We establish trust, right? And you establish that trust with that family the minute you make that first phone call to say, hi, I'm your home care nurse. I'll be out to see you tomorrow. I have you on my schedule sometime between 8 and 10 a.m. So you give them a window of when you'll be there. And if you come on time, or if you know you can't make it between that time, that you call them and say, my schedule's changed. I'm not going to get there now till the afternoon. That's the beginning of establishing trust with them, because they now know that you've given them a time period, and if that changes, that you let them know that. You establish trust just on a phone call. So you're out in that home, and now you're asking them to show you their bathroom. Let me see you walk to your bathroom. How about let's see in your kitchen? And then when you're in the kitchen, you can see how well they can reach to get food if they're getting things out of the cabinet. How well are they going to manage cooking? Can they prepare a meal? You know, so there's all kinds of things that you got to make sure they're capable and able to do to maintain their safety in that home. Of course, we go over things like when we're in the home, we look at if they have throw rugs, wires, even pets sometimes can get in the way. Stairs, like I said. So there's a lot of hazards that do they have working smoke alarms? So there's tons of things that we need to review. And we have to make sure that patient is safe, or they're not really, they shouldn't be admitted to home care, because you're responsible. Once that patient signs those papers and they're now in home health care, you, the home health aide, you represent that agency, and you're responsible for that patient 24/7. Even though your visits are only, you know, that short visit once or 1 to 3 times a week, you're teaching the patient how to manage everything when you're not there, patient and or family. Okay, so that's the goal of home care, is to educate the patient, educate the family how to manage everything at home when you're not there. And if they're not able to do it, then they're not safe, or they're not compliant, and you're going over the same thing over and over and over again, then are those patients really meeting the criteria for home care? Because now they're not complying with what they said they would do. You're repeating the same information over and over again. That makes them ineligible for home care, but you've already signed them in. You can't just say, well, you're not complying, I have to discharge you. You have to give them a chance. So you get those contracts, you can get a contract signed, right? Did I talk about that in the lecture part? Talked about the contract. Did I tell you guys about the guy with the snake? Did I tell you that story? He had a boa constrictor. Okay, this was a true story. We had a patient in home care. I didn't see him, I was supervisor, but the weekend nurse went out and admitted this young man. He was a quadriplegic. He lived in a garage apartment separate from the home where his relatives lived. And in that garage, he had a waterbed, but he also had a boa constrictor snake. So what's wrong with that picture, right? A boa constrictor, you're quadriplegic. Is that safe? Not even a little bit. Who's to say that snake wouldn't wrap around the patient? But anyway, the nurse went out, admitted the patient to home care. And sometimes, particularly on weekends, when nurses admit, they're not going to be the case manager for that case. They're just the admission nurse who works to just do admissions or on the weekend. So anyway, other services went out, PT and the RM went out, and they came back to the office on Monday or so, and they said, there's a snake in there. There's a big, 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 big boa constrictor. So that was not safe, not only for the patient, but for the staff. So we sent the social worker out there to talk about this situation with the patient. And the social worker had a contract that the patient agreed that when the staff came to visit, that the snake would be in the tank. He would arrange for the snake to be put in its tank, so at least there was that safety. But he didn't comply. And so because we had already had the contract and had the conversation, it was all documented, he was discharged from home services because he was not safe and he didn't meet the criteria at that point. But we couldn't have just said, we're not coming back anymore, you have a snake, because that would have been what's considered abandonment. So we had to do a contract with him so that he understood what were the specifics and the parameters of what made it safe for us to go visit him or for him. Frankly, you know, I mean, he obviously had an attachment. This was his pet. You can't tell somebody get rid of your pet. You know, that's not right. But you have to make sure that they understand about the safety piece. So that's just, you know, one example when we did use a contract for somebody.
So I have a question.
Yeah.
If the contract gets breached, do they lose their home care privileges? I mean, I know you were saying it like I mean, contracts are still used for home care and stuff, right?
Mm-hmm. So it's not a legal contract. I mean, they're not drawn up by lawyers, but it's a verbal contract and a written contract that the social worker will write up and sign, and the patient signs. And it's on home care paper, you know, stationery, if you will. So it's legal to the extent for the agency, although at least as far as I remember, they weren't legal from a lawyer, legal contracts. But at least it's in writing then that you had the conversation. Because one of the criteria for home care is it has to be a safe environment.
And then you could pull the home care if they breached. So say the boa constrictor was like, you know, not locked away and it wasn't for them to come in, you could pull their home care privileges, maybe send them back to the hospital.
Correct. Or find an alternative arrangement either for the snake or for the patient. Like I said, because he was basically living alone in this garage apartment. And I don't remember all the specifics, but I sort of remember where they said they weren't super involved. Like they would bring him meals, but they weren't super involved in his care, this particular family. There's all kinds of situations. We had another one of a woman who was an elderly patient who was bedbound, and she was incontinent, and she had a bed sore. She had we used to call them decubitus ulcers, sacral ulcer that was all the way to the bone. It was a stage 4 ulcer. But she was always, whenever the nurse, when they would go out there, she was always laying in her own excrement and urine. And there were also there were bugs in her bed along with her. Anyway, it was a situation that was just inhumane and not okay. And the nurse who was out there called me. I was the director of the agency, and the nurse called in and she said, I can't leave her here. She is not safe here in this situation. She said, I'm putting a call, and it was Philadelphia. This was all in Philly, to Philadelphia Protective Service, Adult Protective Services, APS. And she said, I'm not leaving. Well, to get protective services out to a home takes moving a mountain sometimes. You know, they're very backlogged and all. But this nurse was such an advocate, she would not leave this patient. And in this situation, this was it was obvious neglect and elder abuse, if you will, because of the neglect. Many times people depend on that person's check, their Social Security check. So they'll have them in the house, but they don't really want to take care of them. So this particular nurse, we got the social worker out there the same day, and she would not leave till APS came out there, and Protective Services finally showed up, and they immediately had her withdrawn from the home and sent to the hospital. And from there, she went, I believe, to a nursing home. But this was a case of absolute elder abuse and neglect, and that nurse would not leave until she was protected. Now, should we have admitted her in the first place? I don't know. I don't know what it was like on that first day of admission, but if you have family that's there and they say they're going to take care of somebody, you assume that's going to happen. But not when you get there and she was in that condition, and this was not the first time. So it can get tricky, but you really do, that's part of what the home care nurse is assessing for all of those things. And safety is a huge piece of it, and making sure that the patient stays safe. So it's not just Medicare and Medicaid that does reimburse for home care services. You may have young people in home care as long as they meet the criteria, and they have private insurance. So those private insurance companies will pay for home care, but they usually have case managers that the home care agency speaks to the nurse case managers for the private insurances, and they say this is how many visits we'll allow. They're very restrictive because, as I had said in the voice thread, case managers for insurance companies are all about saving money and reducing expenditures. So while private insurance does pay for home health, it is oftentimes very restricted depending on what the case managers will okay. And then, of course, if the nurse goes out and says, oh, no, this is what's going on, they could talk to the case manager and get more visits approved. But it's all through approval process. Let's see. Okay, I think that's that. Just real quick, you saw the video on the transitional care model. Did you see that one? Dr. Mary Naylor was speaking, and that video was actually in Philadelphia. That's where, so Mary Naylor is a professor at the University of Pennsylvania. When I first saw that video, I was like, oh my gosh, because she was actually she taught me in nursing school. I went to Jefferson University in Philadelphia, and Mary used to teach there. So, but then she had left and she went on to Penn, and she has done quite a bit of research. She speaks extensively across the country about effective discharge planning and the transitional care model. And the whole idea, again, is to monitor, it's cheaper in many ways, and some of this is grant funded also, but these patients that have multiple issues, chronic issues, they may qualify for that home care by the criteria, but not for a long period of time. So in the transitional care model, they are actually followed by a team that is not under insurance issues. So they can follow them for longer periods of time. And again, I believe it's all grant funded. And so that is the model of care to prevent hospital readmissions. And I have the transitional care model criteria sheet. You can take a look at that. But just know that there are these transitional, because transitioning from one level of care to another is where so many times things fall through the cracks, whether it's medications. So a patient going from the hospital to home, or the hospital to the rehab, or back to the nursing home, it is during those transitions of care that we have so much that can fall through, and particularly medications. Okay, so that whole idea of medication reconciliation is so huge in transitions of care. And then, like I said, they had this particular model, and I believe it takes place in other areas, not just in Philadelphia, at the University of Pennsylvania, but where these patients with these particular chronic diseases, they meet the criteria for the transitional care, they'll be followed by this team that is not under insurance reimbursement, restrictions. And it improves patient outcomes. And that's the whole idea, right? We want to improve patient outcomes and prevent readmissions back to the hospital. So, all righty. Any other thoughts, questions about any of that? What I'm going to do now then is put you guys into your groups again. And I have, I'm going to open the class activities. Here we go. Hold on. Make it available. And then I am going to tell you each what your group will do. Okay, so I've opened class activities in Blackboard for today. And there is there's 4 cases. So group 1, you're going to do Harold. That's going to be your case. Group 2, you're going to do the case on discharge coordination. Group 3, yours is on patient education. And group 4 is health education and promotion. So Harold is group 1, discharge coordination is group 2, patient education group 3, and health education and promotion is group 4. I'll put you in your rooms. If you take about 20 minutes to work on your case, and then we'll come back together and each of you will have 10 minutes or so to report on your case. There are actual questions with each case study for you to go through and work on and then report back. So I decided that you'd each have a separate one and then report back, so we all learn about each of those cases, but that you don't all do all 4. So we'll do it this way. We'll see how it goes. Okay? So are you all ready? I'm going to put you into your rooms. Why is it not show? Ah, there it is. Okay. Okay. And, oh, it's so beautiful. All right. Are you guys ready? Any questions? Because I can open, you're already assigned to your rooms. I can go ahead and open it. Are you ready? Yes?
Sure, I'm ready.
Okay.
Yep.
Okie dokie. Here we go. And it's 11:30. Yes. Hi. Did you need help, Carol?
Yeah, a couple of us seem to be in a group that's different from before, because I was in group 3 the last time and
Oh.
and Riley was in group 1 and
Oh, really?
yeah.
Huh. All
Yeah.
right. Well. That's weird. Wonder why I did that. Do you want to just stay in this group? Or well, let me fix it, okay?
Okay.
I'll fix it.
sure.
Yeah.
I'll fix it. I'll get you guys where you need to be.
All right. Yeah, I was just expecting we would be with our clinical group again.
Of course.
Like we had been.
Of course, I understand. So I just, when I saw that everybody was assigned, I just thought it was the same. All right, hold on, I'll be back. Or
All
I'll,
right. Thank you.
okay. always something. Okay, now let's just do something here. Okay. Give me your rooms, give me your rooms.
Hey, Professor.
Yes, I know, we're in the wrong rooms, right?
Yeah.
I know, I'm like, I can't win. I thought it was like everybody was where they needed to be. I'm gonna close the rooms and reassign you guys, okay?
Okay.
Okay.
Hello.
Hi, I'm gonna get you fixed. Hold on now. Once everybody's closing and I'll redo it. Sorry about that. I thought when I looked, I was like, oh, everybody's in a room, but it must have randomly selected it.
Right, and we had Christine and Phoebe as well.
Right, I have my list. So group one is
Is
Mackenzie,
we have
Riley,
to go to
Sierra, Princess. I'm gonna fix it all. Give me a minute, 18 seconds. I don't know, it takes so long to close them up. That's okay, we have time. We're in good shape here today. Okay. Two, one, okay. All right, so let's close, let me close this. If somebody's talking. Thank you. It wasn't just- There we go. Okay. Now, room one is Mackenzie, Riley, Sierra, and Princess. Princess. Okay. Next group two is Phyllis, Diana, Orlando, and Ebriana. Orlando. I don't think Ebriana's here today. Okay. I don't see her. Christian, Phoebe, Carol, and Christina. And then, okay, and Natalie's not, she'll be back. Okay. All right. Should work now, guys. How did you guys get done? Pretty good?
I mean, we got question 1 done, so I feel
Okay.
confident.
Okay, so which group wants to go first? Who hasn't gone first yet? Group 3, maybe? How about group 3 start?
Okay.
Please. Go ahead. Group 3 has the patient education. Is everybody back? You're all back.
Well, I mean, can we go first then? Can group 1 go?
Did
Is that
you?
okay? Oh, okay. Never mind. Christmas is back.
I was just gonna say, did you want group 3 to go first? I didn't hear anything. I was
Yes, I'm
still-
sorry, yes. Group 3 can go ahead, and yours is on patient education. So if you
Right.
can just give us an overview and then how you answered.
Okay. I can't share my screens. Can I just read?
Sure.
Okay.
Yeah, if you're not able to share it, that's fine.
Okay. It says you are readying your patient who is 3 days post-surgical hip repair to transfer to a rehabilitation facility for continued therapy. As your patient's history includes dementia and a high potential for infection, thorough communication is in order to assume optimum continuity of care. The patient's family members are supportive and somewhat divided as to her living arrangements after she has completed her physical rehabilitation. First question was, what data in this scenario is pertinent? You said that the patient is 3 days post-op hip repair, so they might have potential problems with ambulation and they're going to be a high fall risk. That's also relating to the dementia. They have a high risk of infection, and the family members are not in total agreement of rehab conditions. Last bit of pertinent information is that the patient is being transferred to a rehab facility for continued therapy. The next question asked, describe some of your responsibilities within the situation to ensure continuity of care. So since we'd be working in the hospital, we assumed we would be doing discharge planning. So that would include ensuring that the patient has adequate accessibility to relevant equipment in the rehab facility, such as ambulation equipment. And then that's delivered and ready to go whenever they arrive. Education of the family related to ongoing care at new facilities, so what they have to expect, what their roles are going to be in care management and communication with healthcare team. Also speaking with the family about living arrangements post rehab, so if the patient is to return home, but that'll come at a later time. Documentation of relevant information for transfer, which would include meds and last administration, surgery details, recovery details, medical history, discharge evaluations from PTOT and other specialists, and infection control measures. That's all info that's going to go to the rehab facility. Continuing orders that are going to be needed in the new facility. So once again, PTOT, speech therapy, and nursing diagnoses related to post-op care, such as whether they need to put a foam wedge between their legs and recovery, pain management. The last question, after the patient completes her physical rehabilitation, what steps are necessary to provide effective discharge planning? The very first one, Carol said, was going to be assessment of qualification for home health care. So whether or not that patient is going to be homebound, they have a skilled need. Intermittent care, so making 3 visits a week, that will slowly drop off to maybe once a week, and whether there is a reasonable and necessary need. You're also include a family assessment, the availability of family members, education of the family members, the willingness for them to provide care, whether or not they can stop by, and availability of a primary caregiver in the home, since it would likely be intermittent care. We would also include a social worker referral, family education related to their family members' dementia, the home care overall, possible infection control, ambulation, teaching them how to care for their family member. Home safety, Phoebe was saying she deals in the rehab field. initial assessment of the house prior to discharge. So maybe visiting, making sure that it's safe, and the patient's ability to live at the home related to safety measures. So since the patient is demented and they have ambulation problems, you're going to assess whether or not they're able to go up and down stairs at their home, and you're going to work on that maybe with PT before they leave. And that's related to a PT assessment. You're also going to do a home care equipment assessment, whether or not equipment needs to be delivered and installed, such as grab bars in the bathroom or chair lifts for stairs. Nutrition orders, so availability of food and the ability of the person to cook them, and also for their food, which might deal with social workers. Sorry, we have a lot of stuff.
No, it's great. It's very comprehensive.
In a full list of medications to be administered post-discharge, coming up with a schedule, maybe educating the family and the patient, coming up with a calendar, pill boxes, stuff like that. Since they do have dementia, there might be a bit of a learning curve. And lastly, we had necessary skilled services for home care. Once again, PTOT, speech therapy if necessary, home health aide, social worker, and obviously the RN. That's all we had.
Very good. Excellent. So anybody have any questions about that one? It's very comprehensive. I think what let's see, I'm just looking here. I have a list of answers too, see if everything, we pretty much covered everything. I can post the answers, or if, you know what, if you guys send me your work, then I'll post all of your work, okay? So that we can, everybody can see the case studies are all there, but then you can see some of how your classmates answered. Okay, perfect. Thank you. Very good. Okay. Group 4 was health education and promotion. Who wants to speak for group 4?
I'll speak for group 4.
Okay.
Let me pull it up. Sorry about the dog.
Oh,
Sorry.
okay. That's what I love about this online. It's we get to see a little bit of everything, don't we, in here?
Yes, I have many animals.
You have many animals?
Yes.
Snakes.
I don't have any snakes, but I wish I did. I have 4 cats and a dog, so full house.
Okay.
Anyway,
Where'd you get a
health
kitty?
education promotion. So there was Mr. Smith. He went to a health fair. He was just asking the nurse some questions, and they found out that he last saw a doctor that was 2 years ago. So the question is, what further assessment does the nurse need before designing a teaching plan? And we said she would need a head to toe assessment, need to find out any herbs or over-the-counter medications that this person's taking, find out what his access to care was. Is there a reason that it's been 2 years since he's gone to the doctor? Yeah, hang on. Find out his access to care, including transportation, and then what financial or insurance needs he might have that impact his accessibility to care, his health history, any concerns that he has, and lifestyle questions such as his diet, and then if he smokes or drinks alcohol. Some topics that the nurse should include to Mr. Smith based on the current recommendations are colonoscopies, yearly physicals, prostate exams, education about vaccinations, such as shingles and pneumonia vaccines, and then education based on lifestyle choices. So based on the information we would learn in the previous question would correlate with what topics would need to be educated about. And for a teaching plan to cover the topics, I think we should focus on the importance of yearly exams because that seems to be a knowledge deficit for Mr. Smith. So teach about the importance of yearly exams and vaccines, and also using multiple different styles of teaching, such as verbal and written teaching styles. And for number 2, so we're describing the importance of a focus on health promotion. And we said health promotion is primary prevention for adverse consequences of obesity, such as atherosclerosis, hypertension, diabetes, heart disease, and immobility. For context, it was like a school thing about teaching high school students about obesity. And then we looked up this Brecker health promotion model, and the 4 variables involved in health promotion are demographic and disease factors, such as a person's age or their illness, barriers, barriers affecting barriers or disparities preventing proper health promotion, resources such as financial and social support, and then also perceptual factors, how the person views his/her/their status, health status. The 4 components of health promotion we came up with was 1, self-responsibility. Can the individual control their own life and make educated decisions? That's a goal. There are lots of techniques to achieve this, such as public health announcements and educational programs. Another component is nutritional awareness. So that, we want the patient to be able to understand food groups and work with a dietitian to plan a diet that correlates with their disease process. There needs to be education about the relationship between diet and diseases. For example, like renal diets and things like that, and like fluid restrictions for CHF patients. Stress reduction and management. Prevention and treatment of stress can have a direct impact on physical health, including quality of life and disease risks. This can be done with yoga and deep breathing. And the final component we came up with was physical fitness. So the patient needs to have an understanding of the importance of it, and should be able to perform their ADLs, and that performance should be evaluated to see if there's something that we can do to improve, such as equipment or having a home health aide. This can be achieved through active and passive range of motion and physical and occupational therapies.
Okay. All right. Very good. Very good. So health promotion is different at different levels, different life ages, right? So how we do health promotion for someone who's young versus someone who's elderly, you have to take into those factors of their readiness and how they learn. So very good. Okay. So if you could send that on to me, then I'll go ahead and post that. Very nice job. Okay. How about group 1 then? You had Harold.
Yeah. Do you want us to share the screen or?
If you can, that would be fine. I will post it.
Oh,
but
never
you're
mind.
welcome. It's however you want to do it.
I was able to share it at first, but now I can't share it.
Okay, that's fine.
Because do you mind summarizing the script? You did it so well.
Okay, so basically, Harold is a 61-year-old man who has diabetes, and he's had it for the last 40 years and it's been well controlled. But Harold, I guess, has lived with his mother all his life. She gave him his insulin every day. She cooked for him every day, and his mom died. And now you have this grown man who don't want to do nothing for himself. He doesn't want to cook for himself. I'm assuming he's not taking his insulin because he probably doesn't know how to give his insulin because he had it for 40 years. So he's 60, which means he had since he was 20. So his mother has just been doing everything for him. When he goes to the store, because he doesn't want to learn how to cook for himself. So he goes to the store and he gets like donuts or he gets cake and he gets ice cream. And so he also has a pressure injury. And he doesn't want to take care, like, I guess when he saw a nurse, and the nurse was like telling him like, oh, it's starting to heal up because like it's a beefy red color, which is good. And she wanted him to take a look at it. He was like, oh, I'm not going to look at it. I'm not going to touch it. So he has no interest in trying to make sure it doesn't get infected. He has just no interest in doing anything for himself. And then he has a niece who lives about a half a mile away from him, and she comes in the evenings. And so like when the nurse basically said, like, what if we get like a home aide for you, like to have like prepare meals for you? His response was, oh, I don't want anybody in my mother's kitchen. Only family can cook. That's what family's for. So he doesn't want to do anything for himself.
Okay.
Yeah. So honestly, we only got to the first question because we spent the last 5 minutes trying to figure out what the second question meant because we didn't really understand. But for the 4 points to the first question, the first asked for self-care, who was responsible for the health care decisions and actions. We decided because there was nothing in the script stating that he wasn't cognitive. So we stated due to him still being cognitive, we assume he would be responsible for his own self-care. And as a nurse, we can suggest and highly encourage him to change his ways, but we can't force him to comply. And then it said, the next question was, in the context of family and community, would the niece be responsible? So we suggested that we can have a sit down with the niece and the patient to try and see if the niece can bring healthy options for the next day for her uncle whenever she visits in the evening, to try to, so he doesn't go to the store and buy donuts and cake and stuff. And maybe like she can try to check on his wound for him. And I don't know how compliant his niece is, because his niece could probably be busy. We don't know that from the script, so we can only like assume that she'll help further with his wounds and stuff like that. So some focuses, we wanted to first assess if the patient is even mentally able to take care of himself, since in the script it doesn't say. And then continue on from that, we can educate the patient on the importance of him having self-care, especially since his mother is no longer around to do everything for him. We could educate him on his medication regimen and his wound care management. We will also do a depression screening and see how he copes with the loss of his mom, because that could also be due to why he doesn't want any help, especially in the last text, he says that he doesn't want a home care aide because he doesn't want anyone besides family in his mother's kitchen. So maybe he's not coping well enough to want additional help, outside help. And then we would also probably refer him to a dietitian if possible. The only thing we really had for continuity was to, in the text is stated that he would go to the clinic, and every time he went to the clinic, he would see someone different. So he will always have to repeat 3 times what was said. So in our mind, we would try to establish a long-term primary care physician for him within the area and within his insurance, if he even has any insurance.
Right.
That's as far as we got. We couldn't really understand what question 2 meant. So we wanted to call you, but then you put up 1 minute left. So we were just like,
Oh, okay.
yeah.
So the second question was, state 2 likely basic or physical needs this client may have. Is that the one?
Yeah. So we didn't really understand like what exactly.
Okay. So what are his problems? He's diabetic, right?
He has a pressure wound.
And he has a pressure ulcer. So 2 basic or physical needs that he's going to have would be
wound care and insulin management.
Right. Diabetic education. And you mentioned that about setting him up with a diabetic educator. Yep. So those would be his needs would include wound management, natural care of the wound, science. What other, when you're teaching about wound management, what else besides how to actually do the wound would you be teaching?
Diet. To increase proteins.
Right. Good.
I guess, I don't know, you said do it, like how to change it and make sure to let him know to clean from from like the circle from inside to out, so he doesn't get like infected.
Mhm. Right, and Phoebe wrote in chat, infection, yep, so signs and symptoms of infection would be important to teach him also.
Changing position.
I'm sorry?
Make sure he knows to change positions.
Right, to prevent further breakdown. Okay, good.
I just wanted to say, it doesn't actually say if the ulcer is a pressure injury or not.
No, it doesn't, you're
And
right.
since it's on the ankle, it led me to believe that it may have been related to poorly controlled diabetes instead of necessarily pressure. So, you know, if you're thinking about the nursing process, really assessment of that injury, how it happened and where it came from, like maybe like because of the diabetes, there's poor circulation in the feet, but then like a pair of shoes that's too tight is starting the skin breakdown, you know? So,
Yep.
so that assessment of what it is and basing your education of wound care and future wound prevention on that,
Okay.
which I think is also intimately tied to the dietary and disease management aspects.
Yeah,
of it.
right, exactly. Diabetes instruction, which would include realizing, particularly with the feet, and because there is the issue with decreased circulation, that he could develop these ulcers, and it could be from the shoes being too tight. It could just be because of the diabetes and the peripheral vascular disease that he has these ulcers, the wound from that as well. So yeah, you want to include all of those pieces. So, but I love the way you told his story, Mackenzie. It was great. One other, let's see. So the goals would be what?
I would put patient will remain infection free from his wound care, and then patient will be able to demonstrate proper insulin technique for administration.
Okay. And then preparing and eating healthy meals as he's able to demonstrate. But are we even going to get that far? Because Harold is certainly pretty set in his ways, isn't he?
Pretty much, yeah.
So how do we even get there in the first place? How are we going to even reach him? How are we going to meet him? You know, again, it's the idea of trust, right? So to the very first question, the self-care, who's responsible for the healthcare decisions and actions? And you're absolutely right. Your group came up with Harold is ultimately responsible, but we have to make sure he's mentally capable of making those decisions. So that's true. But again, establishing trust and showing concern for him and meet him where he is and ask him what he wants and how he plans to manage. So kind of putting it back on him. So Harold, your mom is, you know, acknowledging that is the loss of his mother who did everything and asking him, how are you going to do this on your own? Meeting him where he is and finding out how he thinks he's going to manage. And I think you said about social work, so would be good for somebody to counsel him. And getting him set up with the doc is great. So you guys did a nice job. So far, you all done a really, really great job. And then the last question was, oh, we talked about that, the nursing actions, which was talking to the niece, getting the social worker. So, okay. All right. Very good. Excellent. I'll post your answers for that one next. So our last group is 2. Group 2. And group 2, yours was on discharge coordination.
Correct. So we had 2 different scenarios. The first one was a 74-year-old who had right knee replacement. So he's being sent home on a limited range of motion knee brace. So it's one of those ones that you can increase it, like the settings per the doctor's orders. Is also on crutches that are going to be non-weight bearing. So when he goes home, he's going to have physical therapy and he has to follow up with orthopedic. He is referred to some home nurse visits if needed. He's going home on Lovenox, some hydrocodone, and then also some Colace. And his daughter, who doesn't live with him, is planning to come stay for several weeks. His wife is, he is a widower, and so none of his kids live at home. He lives by himself. So that's kind of a summary of it. Ask what preparations should the nurse make in advance before attaining necessary community resources and referrals before the patient's discharge. So what type of house does he live in? Is it a 1-story, 2-story? Is there steps that he needs to go up and down? Does he know how to administer the sub-Q meds? And if he does, then maybe see if his daughter's available to teach her as well. How far is the bathroom away from where he's primarily going to be staying, because he is going to be on COLI, so he might have that oops moment where he has to go. How many weeks will his daughter actually be there? It just said that she's going to be there for several weeks. So will he need home care while she's there, or maybe when she leaves? It did talk that he does attend a local church, so find out what church he attends and how he'll get there. Assess his ambulation report from the physical therapist to see exactly how limited he really is. And then for his incisions from his knee replacement, teach him on the wound care before he's discharged on how to take care of that.
Okay.
And then it said, what necessary community resources and referrals will the patient need? We said a DME referral for maybe possible handrails or bedside commode if the bathroom's not near where he's staying at in the house. Maybe like a taxi access to go to church to take him around when his daughter's not there. Possibly maybe a case manager, depending what type of insurance he has, to help coordinate his care for all the different providers he'll be seeing. And then also before he's discharged, schedule that follow-up visit so he knows the date before he's discharged or when he needs to come back to be seen. Also, if the home nurse is no longer available, or if his daughter's not there, maybe set him up with like a home health aide or private duty if they can afford it, to help him with some of those other things. And then with nutrition, when his daughter's not there to help prepare meals, maybe see if he would be eligible for Meals on Wheels, or how he'll actually eat if he can't get up and move around. And then our second scenario, we had a 67-year-old female patient who was discharged from COPD. She has past medical history of colon resection related to acute diverticulitis. She developed a surgical wound infection that requires daily wet to dry wound packing and IV Zosyn. So she's also going to be discharged with home oxygen. We didn't have a lot of time to spend on this one, so we don't have as many answers, but it says to manage her care at home, home care visits were ordered. What would be involved in setting up the first home care visit? Well, first we would need to pick a date and time. Oxygen delivery set up. So since she is going home on home oxygen, that would be something we would want to make sure it's there when she gets home, in case she has an incident where she needs it really bad. And then confirm if she lives with any family, because the scenario didn't say, is she living at home with anyone? Does she have anyone else there that can help her? And does she have any pets? Like I said, we didn't get a lot of time, so we moved on to the second question. And it said, describe the nursing assessments and management that would occur during the visit. We would develop a contract with the patient, maybe assess her range of motion and gait, how she can, if she can get up and move around, go up steps, etc. We would do a wound care assessment and education on how to take care of it when the nurse is not there, and then set goals with the patient to be free of infection. And that's kind of where we ended.
Okay. Very good. Very good. And you did say medication, right? When you, on the first case, when you were reviewing on the discharge planning?
We specifically picked the sub-Q ones because that one would definitely, we want to make sure they know how to administer them before they're discharged. Yeah.
Okay. Very good. Okay. Any questions about any of that? Good. Okay. All right. Well, you guys did a nice job on that. Very good. Couple things and we'll end for today. On the windshield survey, I listed some instruction. I don't know if you saw that, but basically just use this as a guide for when you do your reporting also. Okay, so that's listed under the windshield survey on the community site. And when we talked, the other thing I meant to say to you earlier, when we had the conversation Monday about infectious diseases, and I'd asked you about the STDs. So The only thing that's important for you guys to really understand about STDs, and it really was what we were talking about anyway, which was about tracing and how we trace anybody who has any kind of communicable disease, so that we inform anyone who has been in contact with that person with the infectious disease, so they know to get tested to make sure that they're not infected or a carrier, that they could continue to infect somebody. So you don't need to specifically know STDs per se, but just in context of infectious diseases and how we stop the spread of. And one of the big ways, of course, is testing and tracing, and then depending on how that disease is communicated or transmitted, we educate how to prevent the infection depending on the type of transmission. In other words, whether it's through body fluids, direct contact, or through droplets, which is when we would use our masks and social distancing and et cetera. So depending on the method of contact or transmission, that's the education that we provide when we're talking about infectious diseases. But with all of them, we do tracing and we do testing, and that's to help stop that spread. And of course, educating on vaccinations, which is ultimately the idea is to stop the spread of the disease by people being vaccinated. And do you guys understand about herd immunity? I keep hearing the word herd immunity. I want to make sure you understand what that means. That if enough people in the population have been vaccinated, it will stop. We'll have enough immunity that the disease doesn't have enough hosts to get it, to continue the spread of that disease. So just so you understand about that. And think about vaccinations and disparities also, and who's getting those vaccines first, and access to them is as a disparity. So I wanted to just bring that to your attention as well. All right. Okay, any closing thoughts, questions, comments for the good of the world?
I actually have a question.
Yes.
On the simulation for next week, I saw you uploaded that.
Yes.
Not go on campus, we're just doing that at home on our own, or?
So there's two. So there's one we'll do on campus, and that's George Pello.
Okay.
That one we'll actually do. He's a home care patient, and you're going to, and I'll post those groups. You'll probably just come in your clinical. I have to decide whether it's going to be 3 groups or 4 groups. So I'll have that posted for you by Monday, so you'll know.
You don't need to do anything currently with what's there right now.
No, the only one that you'll do at home is it's a second scenario, and it's Butch. I want to say Butch Cassidy, but it's Butch Sampson. And he is a homeless veteran, and his case is really his transition of care and how we manage somebody who's who's homeless. And then he goes to a facility, but he's not compliant there. And so it's really a case study that I think it's just so valuable to, again, see another situation of what is reality, and how we provide this care to different people in different settings. And in this case, it's a homeless veteran. So George is actually in home at his daughter's home. That one will do face-to-face in simulation. But then Butch is one for you guys to just work on. And I posted it now because you have a week to get that done. And then I created a Dropbox for that, as well as the windshield survey. So each of you will complete your windshield survey, right? And then you'll present together as a group. That's because I know you're doing it different in group 1, right? You're actually doing the survey, right, Riley? But you're giving the information so everybody can fill it out themselves. Is that how you're doing it? Can you refresh my memory?
Yes, that's what we have discussed doing.
Right.
And what we talked about in class on Monday is just having one member of our group drive through, take a video, and share that so that it can be done in a socially distanced way.
And so we're all breaking it up and we're all doing our part. Like not one person is just doing it. We're all doing a part
Correct.
collaboratively. He's just recording the video for us.
Yeah, in your group. Yeah, yeah. So everybody really needs to be able to assess that community on their own, whether it's through a video that Riley's doing, or each of you are able to actually do the drive in that neighborhood and then come back together and collaborate and be, you know, with answering those questions. And then we're going to compare and contrast how you're identifying strengths and risks within that community. And then the other questions that I posted last night or yesterday afternoon for you to use when you're presenting. Okay.
A question about the simulation though, with it was like 4 different Word documents in reference to the simulation.
Yes.
So are we supposed to go on to, are they going to be broken up to 4 different patients? I know it's the same name. It's going to be 4 different scenarios in the DocuCare to go into, or do we do it and then print it out and then go back and do the second one and print it out?
Let me go back and look at that. So for Butch, I'm looking right now on Blackboard. Butch is there. That's just showing you're not actually doing the simulation. The bottom line is you're going to answer the questions for Butch after you follow the instructions. You can, I posted all 3 of the different simulations just because it gives you a little snapshot of him at each step of the way. I'll try and consolidate it so it doesn't look so overwhelming. Okay, I'll try, which is what I did with George. George is just one synopsis of all 3. Because basically the bottom line is you're doing the 3rd simulation. I'll redo it and repost Butch so that it's a little less confusing for you. But the instructions, which says simulation for Butch Sampson revised, that's the questions that I want you to, with the instructions. It's a monologue that you'll listen to of Butch speaking, and then there are some questions related to Butch's strengths, your concerns, prioritizing your care for him, patient education, etc. So I'll try and I'll go back and summarize it in a way that it doesn't look like it's so much for you to have to read through. Okay. I'll make it a little easier for you in that.
Okay. So the only thing which we are required to submit are the answers to the questions in the document titled Simulation for Butch Sampson.
Correct.
And that is going to be due through Blackboard on a Dropbox at the end of Wednesday, next week from today?
Yes. Yes.
Okay, thank you.
So I gave you chart materials for all 3, but because some of them include his, when he was in the hospital, which is simulation 1, it includes his food intake, because I believe Butch is also diabetic, which is not unusual, and his food choices are listed. So, but what I'll do is I'll go back in and I'll put it all into one document for you to use as your reference, and then DocuCare, and then simulation for Butch Sampson revised is the actual one with the instructions of what you need to submit. Okay. And then for George, let me go back. Ugh, I know this is always, I'm going to end up losing, I have to go all the way back out. Unfortunately, that's what happens. Let's see if I can get to it without having to go all the way out. Okay, here it is. So George Palo's simulation is, that was the assignment for the Dropbox, hold on. sim prep, under community sim prep. That's actually, okay, so I have not opened George up yet because that I won't open until next week so after class on Monday, I'll open George Palo. I opened Butch now, so because you have time to work on that at home. Okay, so the actual simulation will be George Palo, and you have it, he's not opened for you to visually see it on Blackboard yet, because I mean, I was waiting until next week, but if you want, I can open it now. Would you guys want to see it now? Just the community sim prep, I'll open it. Let's just, and that way you can do it on your time, okay? So there, George is now opened. Okay, so under community, there's a folder now that you, if you are in Blackboard, you can see it says community sim prep, and that's the patient information. And I did that one as a summary. So I'll do the same thing for Butch. So it'll be less, it'll just be sim 3 that has consolidation of everything. All right. DocuCare has both cases there. I put them on yesterday. There are some tools for George that you'll see. But again, that sim we'll do next week. But Butch, you have this week to complete that one. All right. One other thing that I wanted to tell you is under home care and hospice. I'm going to open it right now. And this is a activity. It's under classroom activities for home care for today's class. And it is actually a home health case study and community health scenario. And it's list your patients that you're going to see for the day, and then things change in your schedule, and it's prioritizing your patients and that sort of thing. So I will open that for you. And again, that's just for your practice, for just to help you with more learning, because I try to, on community, there's a lot of information that gets posted, but it's because you don't have a book. So I try to give you what I can to help you with your studying, to help you with understanding. So this home health case study is just, and I'll post the answers so you can see both, okay? And that's just, that's for you all to have as a study, to help you with study. And I will add a few more study guide materials that you'll have to help you with studying. Okay.
Ms. Button, I know it's kind of delayed.
Yes.
But for the classes on Wednesday, do you have to wait until Tuesday to open up the information for Wednesday?
Me for next Wednesday?
Yeah, so like when we have the classes on Wednesday.
I just opened it now, so he's open for you for simulation.
No, I meant in general, like, you know how yesterday, today's information became available?
Yeah, and that was, you know what? I posted all of that. It was all there on Monday. Unfortunately, it was my oversight that the actual class was not opened. That's what happened. And thank you, Carol, for sending me that email. I felt terrible because it was all there from Monday. Sometimes it takes me, because I had to add, I change it up. I don't leave it the same every semester. I try to, you know, make sure that what I'm giving you guys, and especially this semester, there was a change in curriculum. So I had to update a lot of things. So it took me a little longer to get it all done and out there. But I had it there for you all because I worked on it. It was all ready and it was posted, only I didn't realize that it was unavailable still to you guys. So it was there, but it was my fault. I take full responsibility and I apologize for that. But anyway, so I will have Monday's information. I will post it for you by, let's see. I'll try and get it to you either tonight or tomorrow, okay? I'll do my best. It's pretty much ready to go. Because I know it's a lot of information, and like I said, I do try to get it out there early, and I opened up for next Wednesday. Your George is already opened, and the only thing I need to do is open for disaster nursing, which is Monday. But I just want to make sure that the PowerPoint is what I want it to be, and my voice thread is okay, and I'll get it there. But I can open it for you, but the voice thread won't be ready if you want to start looking at the readings and things. Okay, but give me to either, so Thursdays and Fridays I teach at the college with fundamental students. I don't know what's going to happen because we're supposed to get quite a bit of snow here tomorrow. So I don't know if the college is going to be open. If they are, then I have to be over there, and it won't be till tomorrow evening that I'll have everything for you. But I'll work on it today when we're done here, and maybe I can get it done by today. Okay.
Well, thank you. I just asked because on Tuesdays we have our clinical. So, by the time we get in and it's like, oh.
I know. And I knew you guys had clinical, which is why I was so purposeful to get it up and ready for you, on Monday, right after class. I had to finish one little piece and I posted it. And then it wasn't until Carol sent me that email, I went, oh my God. And I saw it was unavailable. My heart sank. It did, because I know that you guys have clinical on Tuesdays. And like I said, I own it. I missed it. So I'm not going to let that happen again. But thanks, Princess, for understanding. All right, guys. Okay. All right. Any other questions? Thank you all. Have a great day. And I will see you on Monday. Stay safe.